Hi, thanks, Shrove. So hi, everyone. As Shrove said, I'm Jude, I'm a GP, and this is my first webinar doing with BiteMedicine, so I hope you all enjoy it. And at the end, if you've got any comments or feedback, feel free to put them in the chat, and also feel free to ask questions as we go through. I'll try to keep an eye on the chat box. So we're covering today rheumatology, but in particular focusing on SBAs, so single best answer questions. So it's going to be quite interactive. We're going to be using something called menti.com, which I'll talk you through in a moment, and we've got a code for you to use. But in this first bit, it might be a good time for you to bring up that website on your laptop or phone or whatever you're using so that you can take part. Just a bit, many of you may already be using BiteMedicine, but if you're not, just a bit of an introduction about the different things as well as these webinars that are available. There's a massive question bank on the website that covers all sorts of different topics and takes you through some really key and useful things to help with your exam prep. And alongside that, there's the online textbook, which goes through the full sort of patient journey and key parts of, again, multiple core topics. So check that out if you haven't already done so. The aims and objectives for this evening, we're going to cover, it's a bit of a broad overview, so we're not going to be going into any individual topic in a huge amount of detail, but aiming to cover quite a few different things. Some of them are common rheumatological conditions, and other are rarer but are quite important and sort of common ones that can come up in exam questions as well. And we're going to be focusing mostly tonight on recognising the diagnoses based on clinical features. So we will go into some investigation and management as well, but the core focus is going to be on the diagnosis, picking up those key symptoms. And as I said, there's going to be some practice questions as we go through. If you've not already done so, if you don't go onto the website, the code for some reason doesn't seem to be showing up there, but I've got it here, so it's, I'll try and type it in the box as well. So it's 19053290. You should be able to see that in the chat as well, and if you put that in, that will add you in. So going to be roughly about 50 minutes, give or take a little bit, depending on how long things take, and we'll get started. So the first thing, this is potentially a little bit obvious, but the first thing I wanted to cover is kind of what are rheumatological conditions, and they tend to be conditions that affect joints, muscles, or tendons. They're often inflammatory or autoimmune in nature, and as well as the joint type symptoms, they often have lots of systemic features as well. And it tends to be those systemic or specific different symptoms with the diagnoses that make for really good exam questions. So we're going to jump straight in. I can see on the chat, I think Shrove sorted it, a little bit of trouble with the code there, but in a second we'll move on to our first question. I'll give you a bit of extra time for this first one so that everyone can get on. But our first case is of a 73-year-old woman who presents to her GP with a 4-week history of bilateral shoulder pain, and it's making it difficult for her to carry out her normal activities and is affecting her sleep. She also describes feeling stiff when she wakes up in the morning and has been feeling generally under the weather for some time. So your first question is, given the likely diagnosis based on that case vignette, what's the appropriate next step? And your options are start DMARD treatments, that's disease-modifying anti-rheumatic drugs, refer same day to rheumatology, arrange some urgent blood tests, refer routinely to rheumatology, or trial some treatment with NSAIDs. And I'll give you a bit of time, as I say, I'll give you a little bit extra for this one just while everyone gets sorted on it. We will have a look at, pardon me, people's results in general, but individual responses are all anonymous, so don't worry about giving it a go and taking part. Okay, so just before I move on, if anyone's not getting Menti to work or needs extra time, just give me a shout in the chat, and if not, I'll just give people a second to do that if needed, and if not, we'll move on. Okay, so someone else who's not got the code, let me just, oh yeah, there you go, thanks Ray. So if anyone who's struggling, there will be plenty more questions coming up. So we'll have a look at this one. So I'll just move across onto the Menti screen to see what people are thinking. Okay, so we've got a bit of a mix of things here, which is good. The most popular answer would be to refer routinely to rheumatology, and then we've got a bit of a spread between the others. So we'll go back to the PowerPoint now. The correct answer is actually to arrange for some urgent blood tests. So in this case, the suspected diagnosis or the most likely diagnosis is polymyalgia rheumatica. And the reason for doing blood tests is to look for raised inflammatory markers in particular. So that could be a CRP, an ESR, or a plasma viscosity. And it is important to say that you can still diagnose PMR without raised inflammatory markers, but it's a useful test. You can usually within primary care get some results within a few days to support your diagnosis. It's also helpful a lot with rheumatological conditions. There's a lot of overlap in their symptoms, so it can be helpful to use the blood test to exclude other conditions that might mimic PMR. So you might be wanting to check things like thyroid function tests, creatinine kinase, rheumatoid factor, ANA. So there's a group of tests that you can do to look into things in more detail. Now, I think the most popular answer there was refer routinely to rheumatology. You may do that. So for the vast majority of patients can probably be managed in primary care with polymyalgia, but patients may need to be referred to rheumatology if they're not responding to treatment, if they've got atypical symptoms. You might want to be discussing it with rheumatology if they have symptoms that you're suspecting, but normal bloods, for example. But standard practice would be to check some bloods first of all, and the diagnosis and initial treatment could be started in primary care. So just to go into polymyalgia a little bit then. So it's a chronic inflammatory rheumatic condition, and it's actually the commonest inflammatory rheumatic disease in the elderly population. So it's a key one to know about. And it typically presents as bilateral shoulder and or pelvic girdle pain, and shoulder discomfort being the more common presentation. Usually associated with stiffness lasting at least 45 minutes, and that's worse after resting, and particularly bad first thing in the morning. About half of patients also get systemic symptoms, so quite general things, non-specific symptoms like mild fever, anorexia, and fatigue. For PMR, the mainstay of treatment is oral steroids, and that is usually starting at quite a low dose, so usually 15 milligrams of prednisolone, and then that gradually gets weaned down. And the first week of treatment, as well as trying to obviously alleviate the symptoms, is used as a bit of a diagnostic trial, because if it is PMR, then in that first week you should see a really significant improvement in symptoms. So they say at least 70% improvement in symptoms in that first week. And if you're not getting that, that might be a reason to refer on to rheumatology, because the diagnosis is a bit less clear. Most of the time, patients will need to be on steroids for quite a while, so often 1 to 2 years. And because of that, it's also important to think about bone protection. So do they need bisphosphonates? Do they need PPI cover? So there's various other things to think about, as well as the steroids themselves. And we've talked about the fact that for some people, they may require referral onto rheumatology. And for patients who aren't responding to standard treatment, they can consider things like intramuscular steroids or DMARD treatment as well. So straight into our second case then. So this time we've got a 68-year-old woman who again presents to her GP, and this lady's got a 6-week history of bilateral shoulder pain and stiffness. She's been putting off coming to the doctor, but in the last 2 days she's now got a new headache and soreness in her jaw, so she's got more concerned about her symptoms now. And she's examined by the GP, and she's found to have some tenderness over the left temporal region and also some scalp tenderness. But given the likely diagnosis here, what's the most appropriate next step this time? And again, I'll give you some time to answer that. Okay, perfect. So I think I'll just give you, let's just see if anyone's going to say anything different. I'll give you a little bit more time to answer this one because we've got not as many responses. I'm trying to think about what's the difference between this case and the first one, and how might that change your management? Okay, perfect. So we've got a bit of a split here. That's great. So we've got about half of you, it's changing, just half and half now, saying start treatment with low-dose steroids or discuss with rheumatology urgently. And one for arrange the blood test, like the last one. So in this case, the correct answer here is actually to discuss with rheumatology urgently. The key difference in this case is that new onset of the headache and the scalp tenderness. And the concern here is that the patient has gone on to develop something called giant cell arteritis, which can be a complication of polymyalgia rheumatica. It can occur independently of it too, but in this context, it can be a complication of the polymyalgia. And that is a medical emergency. So that does need to be discussed with urgently, so same day. And unlike the previous case, you've not got that time to kind of definitively or more definitively get the diagnosis with tests. It needs to be referred straight away. A little bit more about giant cell arteritis then, because there was a bit of a split voting on that one. It's a chronic vasculitis, and it's characterized by granulomatous inflammation in the walls of medium and large arteries. And in this context, we're talking about cranial giant cell arteritis, or temporal arteritis, it's also known as. But you can actually get the same process affecting the aorta and its branches, which is known as non-cranial GCA. So when should you be suspecting it? It tends to only occur in older patients, so you should be thinking about it in patients over 50 with any of the symptoms listed here. Headache is the most common symptom for it, and it's usually temporal, but it does actually only occur in about 2/3 of people with temporal arteritis. So the absence of headache doesn't mean it can't be temporal arteritis. Scalp tenderness is another classic one, and often people describe it, noticing it when brushing the hair, for example, tying their hair up, they notice that it's tender. Jaw claudication means pain, pain in the jaw muscle, so it's typically over the masseter muscle after a few minutes of chewing. And this can be a bit tricky to differentiate from things like temporomandibular joint disorders, because that also gives you pain in the same area after chewing, and can also radiate, cause referred pain up into the temporal region, so that sometimes it can be tricky to tell the two apart, and obviously one is a lot more acutely concerning than the other. Sometimes there is, on examination, there may be tenderness or visible inflammation of the skin overlying the temporal artery, and sometimes even a palpable thickening or a nodularity in that area. Now, the reason why GCA is more concerning acutely than PMR is that there is a risk to sight with it, and that's the reason why it's an emergency. Not everybody has visual symptoms at presentation, but they may do, and those might be complete loss of vision, it might be blurred vision, changes to colour vision, so it's quite broad, the changes that can happen. If they do have any visual changes already, then as well as being urgently referred to rheumatology, they also need urgent discussion with ophthalmology as well. So the management is similar in the sense that it's steroids, but it's at much higher doses than for PMR. So if there's already visual disturbance, The ophthalmologists often use intravenous steroid therapy, or if not, very high dose, so 60 to 100 milligrams typically of oral steroids. So that's you know, a lot higher than the 15 milligrams we were talking about before with polymyalgia. Typically, if there's no visual disturbance yet, it's still quite a high dose, but not as high, and it would be 40 to 60 milligrams of prednisolone that was started. Similarly to PMR, the inflammatory markers may well be raised, and the diagnosis is made definitively by doing an ultrasound and biopsy of the temporal artery. But in general, you wouldn't wait to start treatment before having that definitive diagnosis because of the risks with it. Okay, so moving away from PMR and temporal arteritis then, our next case is of a 50-year-old overweight man who presents with a 2-day history of severe pain and swelling in his left first metatarsophalangeal joint. And he has had similar episodes in the past. When the doctor asked about his past history, he's found to have hypertension, for which he's taking ramipril and benzofumethiazide. Given the likely diagnosis here, which of the following statements is true? So we've got checking urate levels is a useful acute test to confirm the diagnosis. Oral steroids are the first-line treatment option. The diagnosis can be confirmed by the presence of negatively birefringent crystals on joint aspiration. The condition occurs more commonly in women than men, and an X-ray of the affected joint would always be abnormal. So have a go at that now. Let's see what we've got. Oh, brilliant. The good majority of you there have got the correct answer. So there's a few different things I want to point out with this one. The correct answer, as I've said, is the one about the negatively birefringent crystals, and we'll talk a little bit more about that in a few slides' time. But at this point, I just wanted to kind of highlight that in practice, you don't need a joint aspiration sample to be able to diagnose gout. You do really to say it's definitely gout, but not every person with suspected gout is referred for this. It's very often treated empirically. The key sort of reason to consider it is either in atypical, very recurrent cases, or if you're considering the differential diagnosis of septic arthritis, and that can be quite difficult to tell the two apart. So it can be really helpful in that setting to be sure that it isn't septic arthritis that you're dealing with. The reason, the other one I wanted to point out, which I think a couple of you have gone for, and it is a bit of a trick thinker on this one, because urate levels are really useful in gout, but not so much in the acute setting. So when there's an acute flare of gout, the urate tends to be deposited into the joint that's affected. So the actual circulating levels in the blood can be quite low or normal at least. So it's not that helpful in the acute setting. When it is useful is to check after the acute attack. So it's often in a first occurrence of gout, it's often checked 4 to 6 weeks later. Again, it's not to say that if you've got a high level of urate doesn't necessarily mean you've got gout, and equally you can have gout without that test coming back high, but it is in general, it would tend to be raised if that preceding episode had been gout. And it's also useful as a marker. So if you end up starting preventative treatment, which we'll talk about, is a useful marker to monitor the effect of that treatment. So gout is it's quite a common cause of a swollen, usually a single swollen joint. It causes significant pain and swelling. Usually the joint's very red, very tender, and very painful to move. So if you ask the patient to move it themselves or do so on examination, passively moving it, it's very painful for them. It's something that comes on pretty quickly. So classically, the symptoms get to their maximum intensity within 24 hours. So it peaks pretty quickly. And it most commonly affects the base of the toe, but it can affect other areas. So ankle and knees are also quite common, but it can affect anywhere. The number of different things that put people at higher risk of gout. It's much more common in men than it is in women. Diet is quite important in gout, so a diet high in purines, and that can come from consuming high quantities of things like red meat, seafood, alcohol as well. There's a number of drugs that can cause you to have a higher risk. The classic one, and particularly one to look out for in exam questions, is diuretics. So both thiazides and loop diuretics increase the risk, but also other drugs like ACE inhibitors, beta blockers do put the risk up as well. And you can imagine that quite often patients are on a combination of those for things like heart failure or hypertension. So they may have multiple medications that are increasing their risk of this condition. Talking of hypertension, just having hypertension itself is a risk factor, as well as various other comorbidities, chronic kidney disease, obesity, and various other things. The acute treatment of gout, so there's two different sort of strands to the treatment of gout. One is the acute treatment, so the person's having an attack right now, and one is preventative treatment that we sort of alluded to briefly a moment ago. In the acute phase, the first line treatments tend to be either NSAIDs, so usually something like naproxen, or a medication called colchicine. And the decision for that depends on whether the patient, typically whether the patient can tolerate NSAIDs, if they've got comorbidities that mean they shouldn't have them, and also depending on their renal function. And usually, if you were to use NSAIDs, you would complete carry on treatment until the symptoms are fully cleared for a day or two and then stop. If for whatever reason patients can't take either of those, or they can but they're not working, then if it's just one joint affected, steroid injections into the joint is another option as well. And for people who can't have any of the above, or have actually polyarticular gout, so it's affecting lots of other joints, you can use oral steroids. So one of the options in the question was about oral steroids, and it is a treatment option, but it's not a first line one. As I've sort of mentioned briefly, for people who are getting recurrent attacks of gout, and recurrent doesn't have to be massive, the guidance is if you're having more than 2 in a year, or if you have lots of risk factors, even if you've only had 1, but you've got lots of risk factors going on that make it likely you're going to have more, then we should be thinking about preventative treatment as well. The main option that tends to be used is a medication called allopurinol, and patients take that regularly every day to try to prevent the gout coming in the first place. And we tend to start quite a low dose, and then that's where the urate monitoring comes in. So that's then checked, usually again every 4 to 6 weeks, and the dose of the allopurinol is then increased until the urate is sufficiently suppressed. I wanted to touch briefly, because again this is a common thing that comes up in exams, on differentiating between gout and pseudo gout. Because clinically it can be quite difficult to differentiate, because they're both causes of acutely swollen, painful joints. But there are a few things that probably realistically are more helpful to know for an exam context than in clinical practice, because in reality the treatment of the two is very similar. So one of the main things is about which joints is affected. So this is a generalization. Both of them can affect any joint, but typically gout affects the base of the big toe, as we've talked about, whereas pseudo gout tends to affect larger joints, so the knee, shoulder and wrist typically. The gout is caused by deposition of monosodium urate crystals in the joint, and we touched briefly about this on the question. So basically, if a patient has a joint aspiration done, the sample can then be viewed under the microscope using polarized light. I'm not going to go into this in a huge amount of detail, partly because I don't really understand it myself in huge detail, but the key thing you need to know is that that test is done. The way the light then refracts on the crystals is different depending on what the composition of the crystals is. And that then gives a different shape, a different colour and a different birefringence to the crystals depending on what their composition is. So the key thing to remember is that for gout, the monosodium urate crystals are negatively birefringent and they're needle-shaped. And for pseudo gout, they are weakly positively birefringent, and they're rhomboid shaped, and that's because the pseudo gout is caused by deposition of calcium pyrophosphate, so it's a different type of crystal. The other thing that can be different is X-ray features. It's not necessarily, you don't have to X-ray either of these conditions routinely, but if you were to, they would often be normal, but gout may show evidence of effusions or erosions, sometimes loss of joint space, although that tends to be quite a late sign. Pseudo gout, again, may be totally normal, could show chondrocalcinosis, which is these calcium deposits, and although that's suggestive of pseudo gout, it's not diagnostic. So moving on then to our next case, we've got a 35-year-old man who presents to his GP with a long history of recurrent lower back pain, which has been worsening over the last year. He finds it eases with exercise, but while he's sitting at work all day or in bed overnight, it gets a lot worse. And it's also associated with some early morning stiffness, which lasts about an hour. Given the likely diagnosis, which of the following statements is not true? So you're looking for the false statement within these, and I'll give you a bit of time to read through those and to pick your answers. It'll be a bit longer because there was quite a bit of reading to do with that one. Okay, let's have a look what we've got. So great, a little bit of a spread, but definitely the majority of you have gone for a positive HLA-B27 is needed to diagnose this condition, and you're absolutely right, that is the one that is not true of those. So it is, the suspected diagnosis here is ankylosing spondylitis, and that is strongly associated with HLA-B27. So about 90% of patients are positive for that. But obviously you've got 10% of people there who aren't. So it's not needed, it's not essential for the diagnosis. It can point you in that direction, but it's not essential. As you've also got some, I think it's about 10% of the normal population, so who do not have ankylosing spondylitis, are positive for it. So it's not a good enough test to be part of these, to be essential part of the diagnostic criteria. Ankylosing spondylitis is an autoimmune condition. The full cause of it isn't understood, but that autoimmune process causes attacks on the entheses, which are where the ligaments and tendons attach to the bones in joints. And that attack then leads to inflammation, erosion of the bone, and syndesmophyte formation, and that's bony growth occurring inside ligaments. And that leads to pain and restricted movement, which are the sort of cardinal symptoms of ankylosing spondylitis. And over time, I think it's quite blurred here, this diagram on the side, but over time, the bones in the spine actually fuse together, and so that restriction of movement becomes quite severe. Typically, again, in a sort of classical case vignette, it would be a young man, but there is more newer evidence is suggesting that actually the rates between men and women is more equal than we thought for quite a while. So it's definitely not exclusively a disease in males. You get chronic or recurrent pain. It typically affects the lower back and the buttocks. It eases with activity, so with movement or exercise, the pain gets better, and it gets worse with rest. So anytime sitting still, in this case, the man was sitting a lot at work, and also overnight. And the reason why, one of those options was about pain being worse in the second half of the night. And again, that's a sort of classic thing that comes up, that people wake up in the second half of the night with this condition, and it's due to the fact that they've then been resting for longer, so their stiffness and their pain has increased. They also do have morning stiffness with this, and it should be present for at least 30 minutes, although it's often much longer to point towards this diagnosis. I'm not going to go through this in a huge amount of detail, but it's just to highlight that there's various different diagnostic criteria that the rheumatologists use for this. It is a condition that needs referral, so if you were suspecting this in a primary care setting, you would be referring on to rheumatology to get a definitive diagnosis. The key things though are this low back pain that we've talked about, so a chronic low back pain. It's inflammatory in nature, so it's improved by movement and worsened by rest. We've got the restriction of movement, and there may well be sacroiliitis on the X-ray, so that comes up in both of these criteria. And then on the one on the right hand side, it is HLA-B27 is one of the things that would score you a point, if you like, in terms of making the diagnosis, but it's not included at all in this modified New York criteria on the left. Management wise, so as I said, needs referring, but NSAIDs, particularly strong ones, can be really effective for the symptoms, so there's no need to delay starting those while waiting for a definitive diagnosis. Exercise is really important, so that can just be if people are already quite active, which they may be, because they may well have found themselves that their symptoms improve with activity, they can just carry that on. For other patients, they can be referred to more formal exercise programs to help them with that. Often it does need DMARD treatment, and for ankylosing spondylitis, the anti-TNF agents are used in particular. Okay, so the next one we've got is a 45-year-old woman who presents with pain and stiffness in her hands. This is worse in the morning, but improves as the day goes on. When she's examined, she's got some swelling over the small joints of both of her hands. So which of the following is not associated with the likely diagnosis? So we've got various deformities and changes here, most of which are linked to this diagnosis, and one of them isn't. So you're looking for the one that isn't. So, perfect. Okay, good. That one must have been too easy. So the odd one out there is a Heberden's node. All of the others, so the likely diagnosis or the suspected diagnosis here is rheumatoid arthritis, and all of the others are deformities that are linked with that. Heberden's nodes are small bony growths on the distal interphalangeal joints of the hand, and they are associated with osteoarthritis. So that's the odd one out there. So rheumatoid arthritis, I'm not going to go into this massively because it's such a big topic and such a common one that it is a really important one to go into, but probably not in this setting where we're trying to get through numerous different conditions. The key sort of things I wanted to say about it are that it's a chronic condition, it's a systemic condition, and it's an inflammatory disease, and that leads to a deforming inflammatory arthritis, typically of the small joints, but it can progress to affect the larger joints and other organs of the body. There are quite a lot of deformities and things associated with it, which are thankfully they're not gone totally, but they are less common nowadays because it's being picked up earlier and the treatments are a lot better. So for a lot of people, they're able to avoid such extreme deformities as has been the case in the past. The key thing I wanted to focus on today was just the factors in differentiating it between from osteoarthritis, because again, I think that's a key thing that comes up in these case vignettes and exam questions. And there's a few different things that do differentiate them. One of which is the age at which the condition comes on. So rheumatoid arthritis can come on at any age, including in children, but the peak onset is with between 30 and 50 years old. Whereas osteoarthritis, again, it can come on in younger people, but it tends to be a disease of later life. So as the joints have gone through more wear and tear and more use, it becomes more common. Rheumatoid arthritis is more of a rapid onset, so usually within weeks to months, whereas osteoarthritis is much slower, so typically months to years, although you can get acute flare-ups of osteoarthritis. So you may get someone presenting for the first time with an acute flare who hasn't presented with their more chronic, milder symptoms. So it's important to be asking about, has there been anything else that's been rumbling along for longer? Distribution is important. So in rheumatoid, it tends to be a symmetrical polyarthritis, so multiple joints affected. Typically, it's the small joints of the hands and feet and both sides of the body affected, whereas osteoarthritis would typically be a single joint or few joints and be an asymmetrical pattern. And again, because it's this wear and tear type process, it's the load-bearing joints that are most commonly affected, so the hips and knees and osteoarthritis. There's a theme, obviously, with all of these conditions we're talking about, or a lot of them with stiffness. So for these more inflammatory rheumatic type conditions, the morning stiffness is a key feature. And for rheumatoid, the symptoms should be worse in the morning after that prolonged period of rest, and the stiffness should take a significant amount of time to ease, so at least 30 minutes, but often significantly longer. Osteoarthritis is the opposite to that, so it's worse with use. So by the end of the day, patients find that their symptoms are worse, and they may still have some stiffness, but it should ease a lot faster than patients with rheumatoid. The final thing, and again, this is a generalization, but on the whole, rheumatoid patients are much more likely to have systemic symptoms, whereas with osteoarthritis, it tends to be limited to the joint itself. The next case we've got is the same lady, so the same lady with rheumatoid arthritis, and she's being seen again 6 months later. Her joint symptoms are actually now well controlled with her current treatment, but she's now developed some problems with her eyes. So they're feeling gritty and dry, and she's also noticed some dryness of her mouth. And when she's examined, there's evidence of blepharitis, as well as some thrush in the mouth and some mild swelling of her parotid glands. So what's the most likely diagnosis here? And your options are anterior uveitis, Sjogren syndrome, sclerosis, secondary amyloidosis, or Felty syndrome. Okay, perfect. Yeah, so Sjogren syndrome is absolutely the correct answer. All of the others, apart from anterior uveitis, which tends to be linked more to seronegative spondyloarthropathy, so things like ankylosing spondylitis, all of the others are either linked with or complications of rheumatoid, but with this particular set of symptoms, Sjogren's is the most likely. So this is caused by lymphocytic infiltration of the exocrine glands, and it is often linked to other conditions, so rheumatoid being one of them, but also things like SLE and scleroderma. But it can occur independent to those, so that you can have primary Sjogren syndrome as well. Key features are, if you think sort of dryness, basically, is the way to remember it. So they typically get very dry eyes, dry mouth, and enlargement of the parotid glands as well, and that's usually bilateral. Sometimes it's a fairly mild complication of things like rheumatoid, and with symptomatic management of dry eyes and dry mouth, it doesn't cause people too many issues. But sometimes those symptoms are extremely severe and quite debilitating. But also it is associated with quite a lot of significant complications that are listed there. So it can be quite a problematic condition. If you were to do some blood testing for this, things like rheumatoid factor and anti-nuclear antibody may well be positive. They're positive in quite a lot of other conditions as well, so not so specific, but the key ones to remember for this condition are anti-Rho and anti-LAR antibodies. And the management, as I've alluded to, the initial management is very much sort of symptomatic relief of those symptoms. So for dry eyes, trying things like lubricating eye drops or ointments, hot compresses on the eyes to alleviate any inflammation, eyelid hygiene. Similar for the mouth, so strict dental hygiene is really important. You can get artificial saliva preparations, or pilocarpine tablets can be helpful for dryness as well. And obviously if they get oral candida linked with it, then that can be treated as well. But they may well also need, sorry, skipping through, more systemic treatments, including DMARDs, and also some stronger treatments are rarely needed. Okay, so we've next got a 50-year-old woman who's presenting with a several-month history of discomfort in her upper back, shoulders and upper arms. She's finding it difficult to lift her arms above her head and to lift her head off her pillow when lying down. And on examination, she's found to have a reddish-purple rash to her eyelids and across the bridge of her nose. So another diagnosis question here, and your options this time are SLE, rheumatoid arthritis with scleritis, polymyalgia rheumatica, reactive arthritis, or dermatomyositis. Okay, so a bit of a split here, and I think that's, yeah, it's continuing to split. I think that's understandable in the sense that there's quite a lot of overlap between these conditions, and in particular with the features mentioned there. So the correct answer is dermatomyositis. The SLE can cause similar symptoms. So it's, as I say, not surprising that half of you there have gone for that. It can cause a very similar distribution of a butterfly type rash. The rash in dermatomyositis tends to be fainter and flatter, rather than the SLE rash can be fairly florid. And SLE tends to, although it can also cause pain, it tends to cause more joint pain rather than muscle pain, which is more common in dermatomyositis. So this is a fairly rare condition, but it's an important one to be aware of, and it's definitely an important one that comes up in exams relatively frequently. It's another inflammatory condition, an inflammatory myopathy this time. So a lot of what we've been talking about so far has been affecting the joints. This one's affecting the muscles. It's characterized by inflammatory and degenerative changes to the muscles and the skin. And there's a very similar diagnosis, polymyositis, which is where you've got the same type of muscle symptoms as this, but without the skin changes. So you tend to get muscle aches and weaknesses of the proximal muscles. So the kind of things that affects, and the kind of things that might be described in a case vignette for this, is difficulty rising up from a chair, climbing up stairs, sometimes lifting objects or raising arms above the head for things like combing the hair. Conversely, though, the distal muscles are actually tend not to be affected, or at least not until very late in the disease. So more fine motor movements with the hands, for example, so doing up buttons or typing, that kind of thing tends to be unaffected. Eventually, the muscles may not just be weak, they may actually atrophy, and that may be visible on examination. The two key things to remember, and the names are important to remember as well for MCQ type questions that come with this condition. So the heliotrope rash is the main one, and this is, they describe it as a violaceous discoloration, so a sort of reddy, purpley, bluey, depending on where you read about it, discoloration to the eyelid, which can also extend, as I said, across the cheeks and the bridge of the nose. This second picture down here shows Gottran's papules, and they are these quite strange red scaly patches that tend to affect the joints of the fingers, but can affect any extensor surface of a joint. Can also be associated with edema, and in particular periorbital edema. So as well as the rash, you might get quite significant periorbital swelling with this. Investigation-wise, so commonly the creatinine kinase may be raised, so not always, but it can be very significantly raised, and that's another key thing that's sometimes asked about in questions is the raised creatinine kinase in relation to this. There may also be a positive ANA, although that's an anti-nuclear antibody, but that may well be raised in other things too. There is an antibody called anti-Me2, so that's me as MI, so anti-Me2 that is sometimes positive in this, and if it is, so it's very specific to dermatomyositis, but it's only positive in about 25% of patients. So if someone has that antibody, they've almost certainly got this condition, but the absence of it doesn't rule it out. Treatment-wise, the main thing is steroids, so it tends to be oral prednisolone, but there's various different things that target the skin signs of it specifically, so it's important for people to avoid sun as much as possible, and if they're not doing so, to use high factor sunblock. Topical steroids are sometimes needed for the skin, and for more severe cases, things like methotrexate or intravenous immunoglobulins are used as well. So our next patient is a 48-year-old lady who's presenting with a history of some discoloration and numbness of her fingers in cold weather. And she's noted on examination to have some calcinosis of her fingers, as well as some tightening of the skin on her hands. She's also got multiple facial telangiectasias and some narrowing of the mouth, but she doesn't have any proximal or truncal skin changes. So given the likely diagnosis here, which antibody would specifically suggest this diagnosis? So there's some here that might be positive in this diagnosis, but could be positive in other things too. So which one specifically suggests this diagnosis? Potentially a bit of a trickier one in the sense that you either know it or you don't, but the antibodies that are linked to these conditions does fairly commonly come up in exams, so it's a good thing to look at. Okay, let's see what we've got. So yeah, so a bit of a split there, and an interesting split. So the correct answer is anti-centromere antibody, but those of you who have put anti-SCL aren't far off, so I'll explain why in a second. So the diagnosis that's suggested here is systemic sclerosis. That's sometimes also known as scleroderma. And there's two main types of it, and we'll come on to the differences between those in a minute. The antibody, this case, is describing limited systemic sclerosis, and the antibody that's linked to that is the anti-centromere antibody. So that's the correct one. But the anti-SCL70 antibody is linked to the diffuse type. So that's not right, but you're not far off with that one, because it is linked to a different form of systemic sclerosis. So it's a chronic autoimmune disorder, and it leads to fibrosis of the skin and also the visceral organs, particularly in the diffuse type. It's again common questions to sort of differentiate between the two types. As I've said, it's limited and diffuse. And the main difference that's often described in a case is the skin involvement. So as the name suggests, with the limited type, the skin involvement is limited to the digits, the distal limbs and the face. So you shouldn't get any skin changes higher than the knees and the elbows. It progresses quite slowly. It tends to be a milder form of the disease because you get less involvement of the organs in the body. It was previously known as Crest Syndrome and is still sometimes referred to as that, but it's a useful way to remember the features of it. So it's associated with calcinosis, with Raynaud's phenomenon, which is what part of the description in that case was referring to esophageal dysmotility, so often there's some swallowing difficulties, sclerodactyly and telangiectasias. And other common descriptions of examination features that you might come across is periorbital furrowing or narrowing of the mouth, and also beating of the nose. And just to come back to sclerodactyly there, so what that means is tightness of the skin of the hands, and it's often referred to as a prayer sign. So I don't know if you can all actually see me on the video, but if you imagine a patient doing a sort of classic prayer sign, if they've got sclerodactyly, their skin is so tight that they're unable to oppose the palmar surfaces of their hands, so they're left widened apart. And as we said, the antibodies with this one are the anti-centromere antibodies. With the diffuse type, you get a much more widespread skin involvement, and especially it's worse in this case in the proximal limbs and in the trunkal region. It progresses much more quickly, and there's usually more significant and early organ involvement. And that can be things like interstitial lung disease, pulmonary hypertension, renal effects, and hypertension. It's important to say that in this, so I think previous on the slide, there were options in there for anti-nuclear antibody, and I think also rheumatoid factor, and both of those may well be positive as well in this condition. But as we've said a few times now, they're positive in quite a few of these, so they're less specific for it. Okay, so we're on to our last case now. So this one is a 24-year-old man who presents to the emergency department with a 2-day history of painful swelling to his left knee. And he also describes some penile discharge, as well as some itching and soreness of both of his eyes. Given the likely diagnosis here, what's the most common causative organism? A little bit longer, there's still a few answers creeping in. Okay, perfect. So there's split here between the two sexually transmitted infections of the options, so chlamydia and gonorrhea. The commonest of the two is chlamydia, so the correct answer here is chlamydia, but gonorrhea is also a common cause. They're all actually, all of the organisms here are causes of reactive arthritis, which is the diagnosis that the case is pointing to, but the commonest is chlamydia. So reactive arthritis is also sometimes known as Rheumatoid syndrome. It's a form of inflammatory arthritis that develops in response to an infection in another part of the body. So unlike a septic arthritis, for example, when the infection is in the joint itself, this is an infection elsewhere that is then causing a reactive arthritis in the joint. It's classed as an HLA-B27 seronegative spondyloarthropathy, and that means that there's an association here as well with the HLA-B27 gene, but an absence of rheumatoid factor. So unlike a lot of the other conditions where rheumatoid factor is positive, here it is negative. It classically presents with a painful swollen joint, and that is most commonly the knee, but it can be any joint. It's often just one, but it can affect several, but it's usually less than 5, and that sort of fits it into that oligoarthritis classification. Also associated with urethritis or epididymoarthritis sometimes as well, or cervicitis in women. And conjunctivitis. So again, there's a bit of a triad here, is the classic triad of Reiter syndrome of arthritis, urethritis and conjunctivitis. There's a few different, again, things to remember in terms of rashes that are linked with this. So you can get circinate balanitis, which is painless vesicles on the penis, and you can get a similar version in women on the labia as well. And then there's this unusual rash at the bottom of the screen here, so Scleroderma, which is these red-brown papules on the soles of the feet, which are quite unusual. So someone who has those, you should definitely be thinking, could this be part of a Reiter syndrome? The main treatment, symptom relief-wise, is NSAIDs, and they're often very effective, but sometimes, especially if it's a single joint, intra-articular steroids can be useful as well. Obviously, if they have got an underlying STI, then antibiotic treatment is indicated, but unfortunately there's not a huge amount of evidence that makes any difference in terms of recovery from the arthritis side of things. And second line, similar, there's a lot of overlap in all these conditions with the different managements, but second line would be oral steroids or DMARDs. So just to wrap it up, we've talked about by no means all, there's many rheumatological conditions, so by no means all of them, but several of the kind of key rheumatological conditions. I'd say for the more common ones, and by that I'm meaning things like rheumatoid, probably PMR, and actually probably ankylosing spondylitis as well. It's important to be familiar with them in quite a lot more detail than we've gone into today. So really getting to grips with the key features, the investigations and the specifics of management. For some of the rarer conditions, now obviously if you've got space in your head to learn all about those too, but the key thing for those is probably more on the recognition of them by the clinical features. And there is, in all of these conditions, there's a lot of overlap in symptoms, but if you try to remember the key sort of systemic ones, so a particular type of rash that comes with it, for example, or a complication, that can make it easier to pick out the diagnosis from these kind of classic case vignettes and exams. And the other thing I would suggest, and it's pretty dry learning, but it's useful to try to get to grips with the different antibodies and what conditions they are linked to. So that's the end. I can see there's a couple. I'll just bring up the chat. So Scleroderma, there's a question. I'll just try and go backwards in my slides if I can. Question there about Scleroderma. So the mainstay of it, just bear with me a second, I'm just trying to. I don't think I'm screen sharing anymore, but the mainstay of it tends to be similar to others. So steroid treatments sometimes. Often it can just need treatment focusing specifically on the skin again. So in some very mild cases, you can just focus on things like significant sort of moisturizing to ease the tightness in the skin and that kind of thing. But often it will require steroids or DMARDs similar to the other conditions. I'm not sure off the top of my head if there's specific DMARDs that are particularly effective. For some of them, there's a lot of overlap between the different DMARDs, but there are There are some that there are specific types that work better, and that's the kind of thing where for the key common conditions, it is worth kind of getting to grips with the specific types that are needed, whereas for the rarer ones, more of an overview is helpful. I seem to have lost the chat there, but I don't know if there's any other questions, but if not, thank you all for joining this evening. I hope you found it useful, and hopefully I'll see some of you again soon on some future webinars.